imagine a woman who's coming in seeking help saying like, I know I'm made a mistake. I'm on drugs and I'm pregnant, but
Yeah.
I need to come off this. And most places will send these patients out once they're medically stable
Mm.
to a detox facility because she was 32 weeks pregnant and far enough along that like something could go wrong. They were like, okay, we're just going to keep her here and we're going to do this here. So all the nurses, no one on my unit had ever done this. And I was like, well,
Yeah.
I'll volunteer as tribute. It just felt so inhumane. Just the pleas, the cries for help. And I know that that's part of it. I know that there's like a mental coming off of drugs, but like literally just watching them say there's nothing we can do for you. And like I mean, I was in tears because I just felt like if this was a woman in labor behaving in that manner, we would have been in epidural. We would have been doing the things like that is, we consider that level of pain
Yeah.
like torturous,
Yes.
but not with a detox.
Is it just
I
because
know.
we don't have a protocol for it, or is it all the stigma or both?
I think it's both because a lot of people were like, well, she made these choices. She has to stick through it and she has to go through this. And I'm like, okay, but that's the problem. She starts down this path. And when it gets to be overwhelming and too much, then she leaves because her
Yeah.
care is not being managed properly. And then
Yeah.
when she leaves, she uses. And then she's like, crap, I'm pregnant. I can't keep doing this. And then she comes back in and she's begging, pleading for help. And it's just this vicious, and I know she's not the only one. And when I asked what the protocol was, they said it's to send them to a facility. And I was like, huh, well, what about pregnant people? And they were like, well, psychiatry manages this. So of course, it's Sunday and they didn't really want to come. I wrote multiple messages to the psychiatrist saying, this woman is in distress. I need help at bedside. And they were like, this is just part of it. And I was like, no, this is not part of it.
This can't be part of it.
So I actually made some phone calls. I know some people in the rehab circles, and they were like, yeah, it used to be back in the day, you would just go to like mental institution, they would lock you in a room and just let you kick and scream until it was all out of your body. Now the government kind of gets you rehooked on either Suboxone or methadone, and
Right.
then you're just kind of a controlled high. But the reality is, there are legalized drugs like kratom and all these things that you can get. They don't have as good of a high, but they're synthetic forms of these other drugs. But the detox is way worse.
Yes.
I mean, she had been on fentanyl, street fentanyl, so that's cut with lots of things during the whole pregnancy. But it just made me realize when I teach my students in OB, we talk about drug use, and I'm like, listen, do not ever shame a mom who comes in smoking cigarettes because chances are she used that to get off meth or fentanyl or something else. And I will
Hmm.
take a cigarette baby over a meth baby any day. The way we bring them in, the way we receive them, the facial expressions you make when they talk about either their sexual habits, because we're identifying risk, or their drug use is going to decide if they're going to continue to open up to
Yep.
you. It
Yep.
segues into what we're going to talk about.
Hi, I'm Sarah Levant, and I'm so glad you're here. Here at Bundlebirth, we believe that your life has the potential to make a deep, meaningful impact on the world around you. You, as a nurse, have the ability to add value to every person and patient you touch. We want to inspire you with the resources, education, and stories to support you to live your absolute best life, both in and outside of work. But don't expect perfection over here. We're just here to have some conversations about anything birth, work, and life, trying to add some happy to your hour as we all grow together. By nurses, for nurses, this is Happy Hour with Bundlebirth Nurses.
Well, welcome to the pod.
Yeah.
I have been waiting for this conversation for months now. I have to tell you the story of how I quote unquote stumbled across Morgan. Morgan came to move and was a part of our culture core. And so the night before registration, we had a very special, intimate, beautiful dinner, our culture core, and which is our volunteer nurses to sort of help us support with the culture we were trying to create at Move. We had multiple trainings with these volunteer participant nurses, and then also our A-team staff, which is what we call like the like paid staff people that were there for Move. And so we had this dinner, and Morgan was I was going to say strategically placed, but like the universe knew, strategically placed directly in front of me. And I'd been on calls with Culture Core for what did we have, like 6 trainings. And so we all like got to
Yeah.
know each other to a certain extent where there was like enough comfort there. But I had no idea. And so I have to tell you that prior to move, me and my mom went to go get our nails done. And my mom, who was head of Culture Core, had pulled all the Culture Core applications and had
Hmm.
them printed at the nail salon and was going through. And she was like, do you know about Morgan and her work? And I was like, I mean, which one? Because there were 3 Morgans on Culture Core.
I know there were several of us.
And I was like, I mean, what do you mean? And she started talking about your work, which all of you are going to get to learn about today. And I'm going to get to learn about today because I've held off on lots of this conversation for the pod, for you. So this is some of the first time that I'm hearing some of this, although we've had multiple conversations and I haven't really been able to help myself. So she started reading your application to me. There was no one else in the salon. And
I hope so.
I know. And I was like, oh, yeah, I do remember her, but I had not made the connection between which face it was from the application. And your background is very impressive and very unique in nursing. So you're going to get to tell us about that. But I was like, ooh, I can't wait to talk with her. And then, of course, you were placed right in front of me at Culture Core dinner. And I don't remember, like, it happened so quickly. We sit down at this beautiful fancy meal, and then you said to me, you use the word near fatal strangulation. She uses this and starts talking about the data on near fatal strangulation. I like had a moment, Morgan. Like I remember
I know. I could
you.
see it on your face, and I was so worried. I was like, "Oh, I just broke Sarah," and
No,
I
no,
just scared
no.
everyone around me.
No, it's so good. We need to be talking about this. But I remember looking at you and being like, I mean, I know conceptually what those words mean, but like I don't
Yeah.
actually know what you're talking about in nursing. Like
Hmm.
I literally know nothing. What do you mean? And then we got talking about your research. And then
I
the rest of
know.
the night, I just was like, I need more. I need more. Tell me everything. And, of course, like we only got so far. And so I'm so excited to have this like very intentional conversation about your, can I say your specialty? I'll let you introduce like your background to it in a second.
Sure.
But and before we get going on this episode and the episodes to follow, because I will give you a heads up, this is definitely not a 1-episoder. This is at least a 2-part, maybe a 3-part, because we're going to get into all the things. And I think, I can just see that like I already have so many questions. But I do want to just give a note that if there are little ears nearby, that like this is probably not one to have on speaker, and to just be mindful of how you feel through this. The topics that we're going to be talking about could potentially be triggering. They could be hard to
Yeah.
hear. And so I'm asking everyone to just, and kind of giving you that heads up. And noting in your own body that if you're feeling like, ooh, I can't, like, I'm getting dysregulated, that you would just pause and come back. We will always be here. And if you feel like you can never come back, then that's okay as well. And I also think that if you are in this work, I'm going to strongly encourage you to come back, because I think the epiphany that I've had is like, whoa, gap,
Yeah.
holy moly. And we've got to start talking about this given the stats. So that's my
Hmm.
intro to you. But please jump in and tell us who you are. And I know, by the way, you have heard her voice before because she was on the opener episode of this season with our move recap. But tell us who you are, and then the work that you've been doing, and sort of like this passion that you have been pouring yourself into.
Someone once told me that once you've lived in the darkness, you can recognize darkness in someone else. And that's why I want to bring a little bit of light to those with a little bit of darkness. And
Mm-hmm.
as every labor nurse is always, we've been there. We've been there at some of the darkest times with families, right? Because not everybody's birth story is the most magical thing, but there's a whole nother layer to this. So when I came into nursing, I knew I started as a doula. So I wanted to go and become a nurse. I wanted to go into that next layer. And I went into labor and delivery nursing. And then I quickly realized that the parents that were not going to take home a bundle of joy were the parents I felt like I was best serving. So I did a lot of extra education on dealing with fetal loss.
Mm-hmm.
So that was kind of my segue to then get into sexual assault nursing. So that term is soon going to be put to bed, and we're going to start seeing, and I'll talk more about that and why. And we're trying to just say forensic nursing,
Okay.
okay?
Mm-hmm.
Because I do so much more than sexual assault.
Yes.
So no longer wanting to put ourselves in this box of this is the only thing that I do.
Mm-hmm.
But that's where I started was sexual assault nursing. So I'm an adult sane. So I do ages 13 and up. Or about a Tanner stage 3 and up. So that still includes our adolescents. Okay. So even though I don't do pediatric work, I still like in my heart, and especially on labor and delivery, when these 13-year-olds come in to deliver, that's a baby having a baby, you
Yeah.
know? And then from there, I started doing my PhD, and my PhD is examining nursing self efficacy and performing near fatal strangulation exams on patients that come into the ER, OBED, or L&D triage. Those are our gateways to the hospital. And when we start getting into the research, you'll see why. Because pregnant women are in a particularly higher vulnerability space. So I just took this
Oh,
20-hour training with Diana Fagno. She's one of the godmothers of forensic nursing.
okay.
She was there at really that inception, writes a lot of the textbooks, is in on the research. One of the things she talks about is the responsibility of the nurse. And the responsibility of the nurse is starting the nursing process, right? Like we start
Mm-hmm.
the process, we identify that there's a problem. And it's okay if it's not your specialty. We all have our specialty, right? Like it's okay that we bring someone to take a patient to ICU and then we take the L&D nurse up there to monitor the baby, right? We all have our
Right.
wheelhouse. But when you start looking at the data, the signs and symptoms in pregnant women are worse when it
Mm.
comes to strangulation and the damage that it causes. And I was like, oh, it makes so much sense because the physiology behind pregnancy, the hypercoagulability, I was like, oh, mind blown. There's studies that show they have statistically more hospital visits, more provider visits. They have more problems, which means we have more hands on opportunities to save them.
Mm.
And we're missing it.
How did you go from, we'll call it sexual assault nursing,
Mhm.
to near fatal strangulation, like as a specialty?
Honestly, when women, men, anyone would come in for a sexual assault, but women report more frequently than men because of just societal pressures and things. But so please know when I talk mostly about women, I'm focusing more on pregnant women and the demographic that our nurses here deal with. But by no means am I discrediting what happens to men. They when women would come in and they were talking sexual encounters and the things that were going on, it was not just a rape, it was a rape and violence. And
Mm.
violence often includes restraint, and a lot of times the restraint would include what we call near fatal strangulation. So hands or objects or arms placed against the throat that would occlude the airway or blood flow. And that is significant. And then once you start seeing this pattern over and over, some research came out. A lot of this ties back to pornography
Mm.
and the increases in all of these things. And then once we started seeing more and more women with the same injuries, the same problems, the same complaints, I just dove right into the research. And I have some really powerful women around me in my center that I work at, and it's just when you put these hive minds together and you start absorbing and talking, and then it grows.
Mm-hmm.
And so we want to keep this growing and we want to keep disseminating awareness about this.
Mm-hmm. Can you also just, for context, because it's been helpful for me to understand, what are
Mhm.
the different ways that you work in, I'm going to say OB, Can I say that? Like, so
Course.
just also so that we know contextually when you say the clinic, you know,
Yep.
clinic
Hmm.
or the center,
Yeah.
um, that
Yep.
like what that means. And then also,
Hmm.
you're a smarty pants and aren't you also teaching?
So I am teaching. Okay, so I work full time as a nursing professor because my passion with L&D and all the things like that. That if we're going to change maternal mortality rates, if we are going to truly affect change in our world, it's going to start with our students. I'm going to send new nurses out into the working force with evidence based practice, a lot of bundle birth and things like that. Because if we're going to make a change, then we have to have a new caliber of nurse coming out into the workforce.
Yes. Yep.
So I do that. And then I also work in labor and delivery. We have an obstetric emergency room there. So I'll lovingly call that the OBED or OBED. And then I also work as a sexual assault nurse or a forensic nurse with Live Safe Resources, which is right here in Marietta, Georgia. So we're right outside of Atlanta, the capital here. And so if I refer to the center or anything like that, I'm usually referring to my sexual assault job. And then if I'm working at, if I say the hospital or something like that, or OBED, I'm doing my labor and delivery. But I encounter both types of patients in both of these hospital settings. And for the first time ever as a teacher, I encountered a patient from the center in my classroom. She
Whoa.
came up to me after class and she said, "It's so good to see you again." And I just kind of looked at her and I paused and I could just see her eyes start to melt a little bit, that like
Hmm.
glossy, emotional look. And then she goes, "You don't recognize me, do you?" And then it clicked. It like, because the part of me that does the sexual assault nursing, the part of me that lives in that hospital space, I can put her away.
Hmm.
I
Yeah,
can,
definitely. You have to separate.
mhm. So
Hmm.
she was not out. She was not on my shoulder. She was not protecting me in that moment. And I just, I was like, "Oh my gosh, how are you?" And she's like, "One," and this is recent, like really recent, like within the
Whoa.
last month. And she's like, "One day at a time." And she's like, "I'm doing something with my life." And she's clearly in nursing school. And I mean, when I say
Oh,
she's at the beginning. And
yeah.
I was like, this is so amazing. And so I realized then and there, I was like, I've never seen one like out in the wild like
Yeah.
this. Like I was not prepared.
This is the part that like we've had this part of the conversation, but I think it's necessary
Hmm.
because when you first used the word strangulation, I was
Yeah.
like, I mean, are we talking real like word like
Hmm.
strangle, like the word?
Yes. Yes.
And so I literally I think I said to you like that's a thing.
Yes.
So
So
that's a thing, Morgan?
it's a thing. So let's have a quick little vocabulary lesson, tiny bit. Okay, so
Please.
remember, choking is on the inside, like you choke on like a
Mm,
grate, right? Like when kids
yep,
put like a little hot dog in their mouth or something. But
sure.
we will often in conversation or our patients will use the word choke. Okay, strangulation is
Yes.
external. Okay, we say near fatal because you didn't die from it, right?
Yeah.
But any compression on the external part of the neck that includes blood flow or airflow, this is very, very dangerous. And you don't need a lot of pressure on the neck. So you remember, you've got your jugular veins and you've got your carotid arteries. Your jugular veins become occluded at about 4.4 pounds of pressure. Okay, the arteries in the neck, it takes about 11 pounds. Now, a strong male handshake is like 80 to 100 pounds of pressure. To do like a
What?
soda can is like 20 pounds of pressure. Okay, so
What?
PSI, yes. So I mention that because I want to give you some reference, right? So we're not
Yes.
talking about, so PSI is how we measure these things. So pounds per square inch, right?
Hmm.
It does not take much to occlude these vessels. Now, you also have some deeper vessels, those are the vertebral arteries. That takes about 66 pounds of pressure. That's a lot of pressure. So if you get all the way to those, and those are the arteries that are really close to the vertebrae, okay? Not the ones that are floating out here in the neck, like the carotid and the jugular. So, but it
But
doesn't
like a
take much.
handshake is 80. So
About 80 to 100, yes, ma'am.
that's as much as a strong handshake.
Strong man, yeah. Like a
Okay.
good, firm, like welcoming
Whoa.
handshake, yeah. And I just, for anyone that does deal with, pediatrics or whatnot, we do not know the numbers for children. Okay. We don't know the pounds of pressure for children. That is just not something that's been tested or that we have accurate data on. So these numbers only apply to adults.
Okay. So this is happening.
Yes.
How much?
A lot. So to back up a little bit when I mentioned, so we saw during COVID that the rates of pornography consumption went up. And there's a lot of really cool research that's come out talking about, and when we see it in pornography, they don't call it strangulation, that's choking. Okay.
Mhm.
So the rough play, the airplay, all of these things. And it became very mainstream, very common. And we see a lot of our young people playing with it. So this became, we see it in pop culture, we see it in music, we see it in different places. We've seen it even in movies, right? So the
Yeah.
quote unquote rough sex.
Right. It's
So
been like sexified.
yes, it is. It's sexy, it's risque.
Yeah.
Choke collars and that
Yep.
S&M type world. And please know I am not begrudging anyone their lifestyle, okay? But it just became more mainstream.
Hmm.
But the problem is not everyone is educating themselves on the appropriate ways to have these lifestyles. And then when you find out how easy it is to damage these vessels and the ramifications if damage does happen, you cannot consent to something that can kill you. That is not an option. Like we don't look at it this way.
Hmm.
Um, and there's a big push for near fatal strangulation and IPV to start being investigated like homicide because we know now that when it comes to strangulation, the Strangulation Institute has wonderful data on this, that they are finding that there are suicides that are really homicides. And it's, yes. And
Whoa.
especially when it comes to our pregnant and recently postpartum women, we are in that they are in that highest demographic. If a woman has experienced intimate partner violence that included a near fatal strangulation, that woman is 700% more likely to experience homicide by that same partner.
700.
Yes. Yes. And if she's pregnant, um, we know that they are going to have more visits to either your L&D triage, the office. They are going to come in more. They're going to seek more help.
Yep.
And these are more opportunities for us to be connecting, doing our IPV screenings and asking these questions because
Hmm.
these are the women we're, hoping to save. I want that 700% to be a 0%.
Yeah.
Yeah.
Well, and we know that domestic violence increases in
Mhm.
pregnancy. Like pregnancy is a risk factor for
Yes,
DV. So,
it is.
um, oof. Okay, but okay, so I remember I was like, so this is happening? Like I feel like I asked
Mhm.
you that like so many times.
Yes,
You told
this
me
is
how
happening.
many times a week do you see someone in your center for near fatal strangulation?
It ebbs and flows. I
Of
hate to
course.
say this, we have busy seasons.
Hmm.
But I would say between myself and the other nurses, there's probably like at least 3 to 5 women coming in on a regular just for like strangulation screenings. And then if you add in the sexual assault screenings that include a strangulation assessment, I mean, we have weeks where there could be 10 or more. And then you'll have weeks where maybe no one comes in. But I mean, this is often.
this is in one center in
Yeah.
Georgia that
And
people are
again,
actually coming in for.
mhm.
That to me, you told
um,
me that at Move, and I was like,
And
this
we
is
have
a
other
real thing.
nurses. So because I have a primary job, there are other nurses that do these specific exams as well.
Hmm.
And I love the women at my center. They are so good about sharing education and talking with
Hmm.
each other. And the other thing is, like, when we have to go to court, one of the nurses I work with, Jenna, she shared, she was like, girls, this is exciting because of the forensic interview and because of this and that. Like, we got him, and she was talking about other things that went wrong, but because of the work that she did and because of the forensic interview and the evidence and the things, like, that was one of the things that would help convict this person.
Whoa,
And it's so, so important what we do.
this is
And
so
sometimes it
layered.
can make or break a case. And, to see all these women in our little group me and we're cheering for Jenna, and we were so excited. I
Yeah,
know.
yeah.
Hmm.
Okay, so then you add a legal component. So then you would be
Yep.
considered an expert witness or a witness or a what would you be in these trials?
So we're just like the arresting officer, right?
Okay.
Like, if someone gets arrested and they bring the officer in, like, what happened, what did they say, or the interviewing officer,
Hmm.
things like that. We will come in, and keep in mind we're talking to a jury. So this is
Yep.
people like everyone that's listening right now that might not know anything about what I do. So we come in, we talk about what is a sexual assault kit, what is a strangulation exam, what is all of this. And we also talk about how emotional and how honestly traumatizing it is to.
Hmm.
We try so hard not to re traumatize our patients, but it's like,
Hmm.
hey, we're about to talk about probably the worst day of your life. And I'm going to ask you to relive it again, second by second.
Yep.
And then I'm going to take evidence and swabs and pictures and photos. And it's very intimate. It's very long, it's daunting.
Yeah.
Um, and we share all of that with the jury. We explain some of the evidence. We explain, it just depends on what they're trying to present. Um, it doesn't take long. It takes about 5 to 10 seconds to render someone unconscious. Like, the timeline is very short. And so when we go to trial, we will have the DA, like, will bring like handouts and things to try to help visualize this for the jury and to try to disseminate this and for people to understand like how serious it is.
Hmm.
Because just like I'm explaining to you, they're going to get on there and be like, what's near fatal strangulation? Like, why do we care about this? Like,
Right.
and like, oh no, you care. And
Yeah.
let me tell you why.
And you didn't know you cared until this moment. Here's your moment.
Yep.
Wow. Okay, so near fatal strangulation is happening
Hmm.
more prevalent than we realize. This feels like almost niche and kind of
Hmm.
like unknown, but how does this relate to morbidity mortality data?
Okay. So, 1 in 4 women are going to experience intimate partner violence in their lifetime. Okay. Of those women at high risk, we'll say between 68 and 80%, they're going to experience a near fatal strangulation by their partner. Okay.
Of the
So,
of the
the 1 in 4. So keep in mind, 1 in 4 are going to experience
yeah.
that intimate partner violence in their lifetime. And then those women, about 60 to 80% of them are going to experience near fatal strangulation. Right? I know I know. So here's the thing. When you start breaking this down, women who've experienced like IPV, including strangulation, are estimated to have suffered like some type of traumatic brain injury. But about 92% and up will end up with some type of traumatic brain injury. Because when we talk about, so anoxic brain injury, right? So
Hmm.
we just talked about pounds of pressure. It doesn't take much and it doesn't take long for us to have injury in that area. About 58% that are strangled along with sexual abuse, and about 9% of those are also pregnant at the same time. So, I mean, that's, 58% of those 1 in 4 are going to get sexually assaulted at the same time. And of those, about 9% are going to be pregnant when it happens. Like,
Like, so
that's
this is
insane.
actually happening, and like we've all been exposed to this without even knowing it.
Yes. So the Strangulation Institute has got great data on this and infographics, and I'm definitely leaning on their research right now. So
Hmm.
I love all of their stuff that they put out. And one of the things they talk about, is about 38% of these women are going to lose consciousness. 97% of them report that the strangulation is done with hands. So it's not always someone using something else. It's just, them using their hands. But the biggest thing that hit home for me is 94% of the women that I talked to with this believed that they were going to die.
Mm,
And when something so serious happens that you think you're going to die, that is a very significant moment in your life,
hmm.
right? Just like we deal with labor and delivery, right? Like they're going to remember the birth of their child forever. This is another milestone moment in someone's life that's going to stay there forever.
Yeah, it's a big T trauma.
Mm-hmm.
Yep.
It
Well,
is.
and then you add, that's the psychological layer
Mm-hmm.
that you add on to this of you're not only dealing with the physiology that could be potentially fatal, and if it's not fatal
Yeah.
today on the day of the incident, it may be fatal later, which I'll
Mm-hmm.
have you talk about, but also you add the psychological trauma and the needs of somebody when
Yeah.
they've gone through a traumatic experience. And then you throw that they may potentially be going straight home to their
Mm-hmm.
abuser. And then you add the like pathophysiology of pregnancy. So now you're concerned about
So
the
that
trickle down,
hypercoagulable state
right?
is, oh, yes.
And what that means for potentially labor and birth, which we don't even think about and we should be thinking about and knowing about. But in theory, like that becomes the risk factor for a complicated, I'm going to say
Well,
pregnancy, labor, birth, postpartum.
yes. And the other thing with this is that there's a delayed fatality. So this is something that we started talking about. And so death can occur days to weeks later after an attack where if there's what's called a carotid artery dissection or any type of pneumonia complication, and this can result in a stroke, which can happen because blood clots will travel from where that dissection is. And this can be small. It doesn't need to be something that we necessarily see on the outside, and then it'll travel to the brain, so causing that ischemic stroke. About 50% of near fatal strangulation cases are not going to have visible injuries on the outside, which is why if someone is reporting this, we always say, I don't have x ray eyes, and neither does a doctor. So
Mm,
at the moment, the recommendation is a CTA or CT angiogram of the head and neck to make sure that those vessels are okay. Um, there have been cases of women dying of stroke, and nobody knew why. It was just always like, oh, a mystery. Why did this happen? Now we know
mm,
why. Now we know why. Back in 2022, Harvard put out an article. It's often referred to in our circles as the Chan article, and they talk about the actual number one cause of maternal mortality is homicide. So when it comes to pregnancy related death, so homicide and suicide, like violent, manners of death, are actually higher than the ones that are happening in the hospital. So homicides with firearms is the biggest one, but then homicide in general being so high, one of the number one predictors of that homicide for a woman is experiencing near fatal strangulation.
I was thinking back to when I was a brand new nurse. I'd have these patients who would just not progress. No matter what I tried, they were stuck. I finally would go on break, and that one experienced nurse, you know which one it is, took over for my break. And by the time I came back, the patient was complete, which is amazing, yes. And I'm so grateful for them. And it was also so frustrating to feel that helpless, to not know what to do, and then ask, what did you do? And they actually can't tell you. If you know me at all, you know that I get obsessed and cannot stop until I find all the answers, and this one got my brain going. I wanted to figure out what the heck so many of our experienced nurses were doing, and more importantly, to finally understand the body in a way that we are never taught. I wondered if there were things I was doing that could either help or hinder the labor process, and by the way, I learned there is. I wanted to equip myself with tools I could use with my hands tied at the bedside, well, both as an L&D nurse, but especially now when I'm attending births as a birth coach and my hands are tied. I'm not able to titrate the pit, I'm not able to call the doc for interventions, and I'm relying fully on the physiology of the body to help labor work. And after reading hundreds, if not thousands of resources out there and putting in thousands of hours of work, I figured it out. And I want to give you that too. If you've ever felt helpless, hopeless, or alone in your practice, you are not the only one. More than 7,000 nurses have now taken our physiologic birth class, and they describe feeling energized, empowered, and equipped for their very next shift. They walk away with practical, repeatable tools they can use with every patient. Not a one-size-fits-all prescription approach, but the ability to critically think your way through any birth scenario. A way to look at the body and know exactly where to start. You can activate physiology and optimize the systems that actually make labor work. Together, we can change the game in obstetrics. So if you're ready to feel confident instead of stuck, equipped instead of overwhelmed, and connected to a community that is committed to excellence, knowing that you're not alone, join me at our next physiologic birth class. It's truly a masterclass for every nurse to apply with every patient. Link is in the description. I can't wait to see you there.
I think that part is what got me, because as I was prepping for move,
Mm-hmm.
we were talking about the patient experience, which by the way, you can take the class yourself. It's now
Yeah.
live and online and anybody can go to it. Not that you need to because you were there, but I'm saying to our audience. And as I was prepping for the patient experience piece, I'm asking the question, like, what do patients
Mm-hmm.
want from their birth? And
Yeah.
my first response was actually like, they don't want to die. And
No.
that is the reality of what patients are hearing, and certain demographics are going to be more likely to
Yeah.
die during childbirth. But I think us as labor and delivery nurses, we think labor and birth, death, and rarely do we see that. And so if we pull it back a little bit beyond just the labor and birth experience, to be honest, like, I've always heard that cardiac is number one killer.
Yeah.
And then I started pushing into that, and I had it on the slide where I'm like, number one is
Mm-hmm.
homicide, suicide. But I remember coming across that and being like, how did I miss that? What in the
Yep.
world? And then I think, isn't substance use disorder in there?
Is in there now. Yeah.
Yeah. And that has been a recent one for me because and actually I was speaking at an A1, a state A1, and they had all the stuff on substance use, and I was just like, I mean, great for them. And then I was like, wait a second, where am I missing this? Like, and maybe it's just me that, like, somewhere in there, like, I've been lost in there, but let's be clear. The number one reason for mortality is homicide, suicide, substance use. And then
Yes.
you start to get into some of the other things. And so this directly links to all of us. We all talk about morbidity, mortality. Let's prevent morbidity,
Yes.
mortality. And so when we got going on this conversation, I just was like, wait, like we've like missed the thing. Like this is like an entire humongous
Well,
potential gap for us.
it is a potential gap, but here's the thing. It's really difficult to train nurses on, hey, you need to do this because we're going to prevent a homicide, right?
Sure.
Like that,
Sure.
that sounds crazy.
Yeah, that's fair.
But when you take a step back and you're like, okay, the study that Harvard put out talked about that the data they pulled was 2009 to 2019. 68% of pregnancy related homicides, like, involved firearms. So we're like, okay, sure, this is a gun problem. No, it's really not. It's way more than that, right? And it took from 2019 until, honestly, there's articles coming out this year that have really dove into this, okay? And Unfortunately, because of the rates we have in the United States, we know that Black women face like substantially higher risk for
Hmm.
homicide and death and all the other things. But nobody has the answer right now to the homicide piece. But the answer is that we were trying to, like, okay, if we can't fix that, let's fix the cardiac piece, let's fix the
Sure.
hemorrhaging piece. Like, let's make and we need to keep making good efforts in those arenas. By no
Yep.
means do I think the data and the things should stop in those arenas. But we really need to get a handle on this other piece too.
Yep.
And where we come in, right, is that if it's truly a health emergency for a pregnant woman to experience intimate partner violence, okay? Because pregnancy related homicides are preventable. And
Hmm.
that's what I want people to remember.
Hmm.
Pregnancy related homicides are preventable. They have checkups, healthcare providers that they get to see, and we know on average they're going to come in more often, which are more opportunities for us to connect with them, to build
Hmm.
relationships. And if they're not ready to leave, okay, we can't make them leave. That's not what we're here
Yeah.
for. But what we can do is we help them get a safety plan in place. So when the moment does come, they know what to do and they're ready to go.
So tell me
That's where
what's a
we come
safety plan?
in.
Like what's in a safety plan?
So there's a lot of things. It depends on where your patient is in the process. Okay. If she's ready to go, then we start immediately establishing, like, okay, do you have pets? Do you have kids? Where are you going to go? Can they get into your phone? Do they have keys to your house? And we start making plans. Now, let's say this woman is not ready to leave, right? She does have kids and they have school and this and that. We go, okay, is it when the person drinks or uses substances? Is that when the problems happen? Okay, well, if he's drinking and using, can we go somewhere else for the night? Can we take the kids and go to grandma's house? Right? We make a plan. We're sitting there in a
Hmm.
calm space, not judging her because she doesn't want to leave, right? That's not what we're there for. We're like, okay, let's make a plan. That way, when things start hitting the fan,
Hmm.
she's not racking her brain going, what am I going to do?
Yeah.
We have a plan. We keep our keys by the door. We know where our purse is at all times because when we need to, these are the steps we're going to take when we need to leave, whether it's forever, whether it's short term, whatever. That's our safety plan. What
Hmm.
happens to the dog? What happens to the cat? Where do the kids go? Because you don't want to be thinking and panicking in the moment when you can't think clearly. You want to
Hmm.
have a plan and you want your patient to feel good about their plan. And then when things start happening, they already know what to do.
Yep.
And
I
that's
think
that's part of it.
I think that's helpful for me to so it's like there is an quote unquote intervention
Hmm.
that can help because I think about, and we'll talk so everyone listening, like I'm going to ask the question about your assessment. What would you see? What like what are the
Okay.
signs and all of that? So we're getting there. But before we get
Okay.
there, I think for me to know that like it's not just rescuing them and saying you need to leave them,
No. No.
and that's actually probably not helpful because it feels so overwhelming and doesn't lead to actually any good outcome. And so, but this idea of
No.
a safety plan does feel tangible and does feel like okay. And me as
Yeah.
a nurse, I'm like, okay, if I can initiate slash and that's my question for you is like I'm not doing the safety plan because I don't know what the heck I'm doing unless I'm trained in it. And so what would be the call? And then we're going to backtrack to like assessment and all of that to get to a
Yeah.
safety plan. How does
So
that work and what's your suggestion there?
So there are great forms and just standard things that you can follow and we can get on your unit. When it comes to safety planning, if any patient, not just strangulation, not just if any patient opens up and there is any type of problem, right? An unsafe environment, okay?
Mhm.
This is all very personalized to that patient.
Yeah.
So the first step is, okay, can we get out of the dangerous situation, wherever that may be? So sometimes it's getting them to a shelter, and sometimes it's driving to a shelter. Sometimes it's knowing, like, hey, when this happens, when you're ready, come to this shelter, come to this place, and then we'll find help you find more temporary housing, something like that.
Mhm.
But they also, like you said, when a person is experiencing intimate partner violence, a lot of, or assault or rape or anything like that, all of their decision making is taken away from them. All of their control is taken away from them. So
Mhm.
the main thing when it comes to safety planning is, how do we let them make decisions about what's going to happen with their care, with their life, and support them in those decisions? So little things to think about, like, you know, taking the facial ID off of your phone, because if your partner,
Mm.
strangles you and you pass out, they can just hold the phone up to you and it reads your face, and now your phone is open, right? So having them do the numeric codes, does this person have access to your house? So do we need to get new locks, right? Do we need to change codes on things? Do they know where you work? So it all depends on the patient themselves. There are different, just generic safety plan questions on different forms that are available free to hospitals and centers to use, that provide some like basic, like, do you have a cat? Do you have a dog? Do you have kids? And like making sure that you cover those things. But the reality is you're having to specialize it to whomever you're talking to and their individual situations. I know one of the nurses I worked with, they had to find a place for a horse to go. And it turns
Oh,
out there are centers that, like shelters and things that will take animals. And somehow they found a place that it was like a rescue barn and it took the
wow.
woman's horse. Yeah. So, I mean, like, there's resources out there that you don't even realize exist until you start digging and looking. And I would have never known that it existed until we had a patient come in who needed that type of care and
Mhm.
that help.
Mhm. So then I
Um,
just download a form and walk them
yeah.
through it, or
First off, there's different like risk assessment type tools. So the DA5, you do need to get certified to do a DA5 like appropriately, but you can look up the DA5. But there's great websites like womenslaw.org has safety planning. There's one through the hotline.org, which is the National Domestic Violence Hotline, and I love theirs because theirs is great. It's almost like the person can do it on their own and they don't have to feel like they have to talk to you about it.
Mhm.
And it will ask them questions and you can walk through it with them. And it's literally establishing all of those things. So when you're talking to your patient and you're finding out like where they live, okay, is that a safe place? And you literally are just checking off. And I don't want to say checking off because that sounds like they're a box, right?
Yeah.
When it comes to planning safety, right, when we're trying to create these safety plans, we're trying to support this person and get them out of this space, right?
Mhm.
So sometimes these tools, these safety planning tools, they're there to remind you to ask about these things, right? Because
Yes.
at first, when I started doing this, I didn't think to ask
Yeah,
about
you're not
facial
remembering.
recognition.
Sure.
I didn't think about asking, like, oh, are you in school? Is this person in school with you? Right?
Mm.
Like, and it reminds you to ask these things of your patient so that you can think about all these potential scenarios that they might need intervention. Asking about trusted people, family. Do they have a code word, right? Like, so code phrases. So if you're my person, Sarah, and I call you and I'm like, hey, remember that book I lent you about Bluey? Are you done reading it?
Yeah.
Super normal thing. And you'd be like, oh, okay. But that's my code phrase. That means I
Mm.
need help. I need you to come over. I need whatever it means. Um, you know, do you have somewhere to stay with? Like, do you have somewhere you can go in public near you? Some
Mm.
like things like that. Like, where are you going to go in case of like an actual emergency? Like, what if they're following you home? Like, it just depends on the situation. So there's basics, and then talking about school, talking about children. And then also we talk about emotional safety in this. Do they have a therapist? Do they have a counselor? Do they have access to this? So that is all part of this. So everything from their home, their technology, passwords on things, children in the home,
That's so
pets in the
helpful.
home.
and all
Yeah.
the things that like I'm never going to think about.
And here's the other
Yeah.
thing too, when we're nurses and we're connecting with someone on that level, and you're talking about these things, it's helpful for me to have those check boxes so I can remember, right?
Of
Did
course.
I ask her about all of these things? Because my personal life is so different from her life. I might not think to ask about a horse,
Yeah. Yeah. Definitely not.
maybe they'll have some kind of crazy fish tank or something that you've got to figure out a plan
Yeah.
for now. Like, who knows? But we want to be able to ask those questions, and we want to have some type of, and so there's tons of resources for that.
So you do the safety plan and then
Mhm.
what? They're left with a piece of paper, or they have a note in their phone, or they have it in their head, or you have it in their chart.
It's so if we do one at the center, sometimes I'll put a copy of it in, like I'll take a photo of it and it goes into their electronic MAR with us. And they can have a paper copy. If we're worried about their partner seeing it, maybe a
Yeah.
paper copy is dangerous. Again,
Yeah.
it's every person's situation. That's why I really like the one at the hotline.org, because that one can be on their phone or in their email. Sometimes going through it and going, okay, like this is what I'm going to do when this happens, and this is what I'm going to do when this happens. A lot of times these women will remember these things, but they can keep it in the notes in their phone, keep it in their email. And if they start to panic and they don't remember, they can easily pull it up. We
Mm,
also encourage, like Sarah, if you're my person, I'm going to send you my safety plan,
mm,
so that if I panic and I call you and I ask for that book about Bluey, you're
yeah.
going to be like, okay, what do you need?
Yeah.
And you can start helping me remember or work through whatever I'm dealing with.
Sure. Sure.
If I ask for the Bluey book, you're like, okay, meet me at the Quick Trip. I'll be there, and or whatever
Mhm.
gas station, whatever safe places nearby.
Mhm.
And those are the specific things that you do with a patient. So they're not meant to be long drawn out documents.
Yeah.
They're short, they're quick, and if you got to get up and go, okay, what do you need? You need your purse and you need your keys. Put them in the same place every time. Where are we going to keep them? Have
Yeah.
her tell you, I'm going to keep them by the door. I'm going to keep them here. And you remind her, okay, when you get home, remember to do this, because when you need that moment, you know where they're at. You have that moment of clarity. Go grab them, get what you need, and go.
Mhm. Mhm.
And we're here waiting for you.
It feels so autonomous versus
Mhm.
what I can imagine could happen when it comes from such a good place, like you care. And I'm like, oh my gosh, you disclose something to me that makes me nervous about your safety or makes me nervous for your life. And I
Yep.
want to help, but like our instinct is, well, you got to run, you got to leave. It's
Yeah.
not that simple. One of the things I talked about at Move slightly was just about being curious, not judgmental, and first thought, second thought,
Mm-hmm.
which you'll learn in the Live Colorfully class if you join us. And I think a lot of that, and even just the like respectful care of like, I respect that.
Yes.
And when you're hearing something that is hard to hear and we want to save them, a lot of us
Mm-hmm.
have a little bit of savior complex in us as well, of like, that's why we got into this work. That I think it's
Yep.
easy to be like, well, they just have to leave and why not? And then we very quickly become judgmental about our patients and about their life circumstances. You told a story at the beginning of this about a patient that you had, yeah, with
Yeah.
substance use disorder. And so, it's like easily we think we know, but also all of us need to just slow our roll and realize we do not know what it's like to be in
Mm-mm.
their shoes.
Here's the thing. When If you're telling her what to do, telling her how to live her life, telling her all, she knows. She knows. She already knows. You're not telling her anything new. You're no different than the person that was abusing her. So instead of belittling her and pushing her down, let's build her up and give her the tools that she needs, so that, and my hope deep down inside is when I empower her. I don't want to give her, when I empower her. When I empower her with these tools, that when the moment comes, that she's going to feel that power inside of her, and
Mm,
she's going to pick up that purse and keys and go. And that'll be the
mhm,
last time, you
mhm.
know? But
Yep.
all I can do is remind her that she is a strong woman or man if I'm dealing with a man, because we do deal with this with
Mm-hmm.
men.
Mm-hmm.
But for we want them to feel strong,
Yeah.
and feel like you do have a choice and you can do this. And when you're ready, we will be here with open arms,
Yeah.
you know?
Well, and how much more empowering that actually is, as stupid as this example is. This is a really dumb comparison, but I think for most of us, many of us can relate to this one more than we can,
Yeah.
like near fatal strangulation, is
Yeah.
um is when you're dating someone wrong, or like you have a
Yeah.
friend that's dating someone wrong. Like I know that
Exactly.
I'm like he's bad for me. I know that like I should break up with him. And you can tell me
Right.
that till you're blue in the face, and like I don't care. I'm going to do what I'm going to do, and
Hmm.
I have to get to a place that I'm ready and I feel settled about that decision to break up with them or whatever. And oftentimes we want to control our environments. We want to control those around us because we're uncomfortable with
Yeah.
what we're hearing, and we want good for other people. So it comes from a really beautiful place, and it's not
Yeah.
actually helpful. What's helpful is for my friends to support me and say, I believe in you. You're strong and you're worth it. And if
You
you're not
are worth
happy,
it.
then you need to like think about that and consider what else your life could look like, and how, whatever, like anything but just telling me what to do. And once again, it's like it's about putting control back in their hands. We talk about that for labor and birth, how important
Hmm.
that is in preventing
Yeah.
trauma in the process, and that's true for life as well.
Yes.
I would love for you to walk me through what a nurse would see in an instance of near fatal strangulation. So someone presents to triage, sometimes disclosing, but honestly, I've worked a lot of triage and I've literally never had anybody tell me anything about being strangled.
Yes.
So
And
walk me through.
the best thing that I've ever seen that kind of gave me this comparison. I was in some training recently with Diana Fagno, and it was a generic little video off YouTube. And it was a dog that had done something bad. And the owner was like, come here. And you see it kind of peer around the corner. And like the owner's making the dog come in the room, and it had torn up something, but its head was down and like turning to the side. And it was just so sad. Like it knew it was in trouble. Right.
Mm-hmm.
And, she paused and she's like, look at this. This dog doesn't look beaten. There's no signs or something, but its head was down. It was turning to the side. It was not making eye contact. It was scared. It was vulnerable. It knew it had messed up. It didn't know how to respond, and it was timid, right? So think about how many women have come in saying, I don't feel right, or I'm not feeling my baby move, or just all of these things, right? And we push it off. Oh, they didn't eat, they dehydrated, this, that, the other, right? Or we put them on the monitor and they're like, oh, well, now the baby's moving because I'm here. They're moving now because she's safe.
Mm.
The, the adrenaline's down, the fight or flight is coming down because she's safe, you know? So they're going to come in and you may not see injuries. You may not see anything, but most hospitals, I say most because I don't want to speak for all, do have some basic safety questions, right? And you, as a nurse, should not ask those with other people in the room. And if you're going to be doing those types of screenings, doing them correctly is so, so important. So, so important. If your patient jumps at being touched, can't tolerate being touched, if you're going to do an IV and you see a bruise and you're like, hey, how'd that happen? Oh, I don't know. I bumped into something. And then you see one on their leg or this or that. Doing that full head to toe on admission is so important because sometimes those signs are under our clothes, right? It's not always on our face and our head. Once near fatal strangulation has gone long enough and there starts to be visible signs, they had occlusion of blood flow or airflow for a while. And when I say a while, we're talking more than 10 seconds. Okay.
Okay.
Because that is, I mean, 10 seconds is a long time when you can't breathe.
Yeah. Yeah.
um, but, if they're arguing or fighting, and keep in mind too, as soon as something is around someone's neck, they're going to stick their hands up and try to start relieving that pressure. So, even if the argument, the fight, whatever's going on longer than that, the consistent pressure might not be enough to give those signs and symptoms right away. Think about like when you hit yourself, how long it might take for a bruise to form.
Sure.
How quick is she coming into you?
Yep.
How quick? Like, so we don't know. So this is why you have those risk assessment questions, right? But if someone were to mention that they had a fight, or they've been arguing, or, they give you some reason to think that you should do more questions, right? There's just something there. You can, I mentioned the danger assessment or the DA5. It's a really good assessment to do. And, it has questions on it that allow you to assess how high risk for homicide or severe injury that person is by their current or former intimate partner.
Okay.
So this tool is an amazing tool. This tool comes up a lot in our training, so it's a great piece. There are also strangulation questionnaires. So there's training, right, that goes with this. But as far as being, labor and delivery or OBED or wherever you work, if someone tells you that they have had some type of physical altercation with their partner, something as simple as, hey, did they put their hands or anything around your neck or over your nose and mouth? Separate it into two questions. Get one for the neck. And then at any point, was anything over your nose or mouth? Or did you feel like you couldn't breathe? If you get a yes to either of those, you need to get more information, right? Just like you would your nursing process, right?
Sure.
Oh, tell me more.
Mm-hmm.
I'm so sorry this happened to you. Can we talk about it? And if they say not now, assess what's happening in the room.
Yep.
Okay. Can we get the person out of the room? Do we need to take a trip to go do a test that doesn't exist in the ultrasound room or something like that so that we can separate our patient without it being obvious? Whatever the case may be. And then there are strangulation questionnaires that you can go through. And then we have there's some great resources on, testing cranial nerves. One of my favorite that someone shared with me is testing cranial nerves with a piece of gum. And I know, right? You can test all the cranial nerves with a piece of gum. I'll share that article with you to share with our nurses. I can't even take credit for it. It's a wonderful article.
Oh, okay.
So very simple. The Academy of Forensic Nurses has a cranial nerve assessment where it has all the little tasks. They're quick because keep in mind, we don't want to prolong these types of assessments any longer than they need to be, right? This is not what a labor and delivery nurse would be doing. A forensic, they could do the cranial nerve test and do the strangulation questionnaires and things. But once they identify that, like, okay, we have something more here, depending on hospital protocol, we can get a forensic nurse in there. We can get whatever in there. But while they're in your care, right, if you know that there's potential that something has happened to the vessels in their neck or something has happened that could cause problems later. In my research, one of the questions that I ask is, have you ever cared for a patient that had ramifications of a near fatal strangulation after they were in your care? And everybody said, like, I don't want to say everybody because but almost everybody said no. And I desperately wish I could go back and start combing through all of their records, be like, no, there was this one and this one and this one. But the point of the question was knowing that so many nurses were just unaware of the things that, had come through their OBED or their ER or like the outcomes. And that was a little sad for me to see that one, but it was a necessary question.
Sure.
And it also brought awareness to me of like how many women came through, because we know, we can see when there's bad vibes between partners and there's tension in the delivery room, dad throws something, or
Sure.
mom can't answer a question, she has to look at him to answer the question, or um how many of those did have bad outcomes and I just don't know about it. And I
Yeah.
didn't say anything. I didn't ask in the moment. I didn't separate them. I didn't do more. Like I
Mm.
just kind of, and this was before I knew better.
Mm-hmm. Are there external signs that would be obvious?
Mhm. Yeah. Yeah. Now keep in mind, like I said, 50% of the time there are no external signs.
Sure.
Petechiae are one of the first things to show up. And when petechiae show up, when you look at the timeline, usually there's occlusion of those vessels for more than 10 seconds at that point. So we look at these timelines to establish like what happened. At 14 seconds, that's when like an anoxic seizure can happen. So all of this comes, by the way, from a study that was done in the 40s, but we could never do this study again.
Yeah.
Okay, this never, never, never. I believe these men were in prison, and they wore a device and it compressed their neck, and they timed all of these things and got all of this. This is just as bad as Tuskegee,
Yeah.
so we will never be able to have this type of data again.
Sure.
But it literally puts what happens, like when there's loss of bladder, when there's loss of bowel. It's a great timeline. We use it a lot when you have to testify. So when you hit about that 10-second mark and you know that they could lose consciousness, they could have all of these things happen, right? You can have petechiae on the scalp, on the soft palate, behind the ears, okay, around the eyes, especially in the eyes. You'll want your patient to lift or lower their lids. You can see congestion in the vessels or even blown vessels.
Mm.
Around the neck, there can be bruising, swollen tongue, swollen lips, scratches. If they use a ligature, which means they didn't use their hands, they use like a cord or something like that, sometimes that will leave an indent. And the way that we look at that, right, is if someone were to try to harm themselves, the angle would go more up in the back versus a straight across the neck if it was done by someone else.
Mm.
And these are, I guess, more obvious. Sometimes you'll see scratch marks at the neck, because if something's around your neck and you can't breathe, you're going to start scratching and pulling at it,
Mm-hmm.
right? Fingernails and hands. If your patients have got severely broken nails, like, and I'm talking like, not just some chipped polish, like if their hands are like broken nails, blood around them, like take a look, right? How often do we inspect their hands? Hands and fingernails are so important, so
Okay.
important. Bruising. Another thing is proptosis, or the droopy eye. But the main things there, dizziness, headache, hoarse voice, sore throat. So you might not have any visible stuff out here, but I'll ask women, this is my first time I'm seeing you. I'll have them look in the mirror. Does anything look swollen to you? Does this sound like your normal voice? And they'll tell you, like, no, my voice sounds different. No, this eye looks a little puffier than it normally does.
Mm.
Mhm. With our pregnant women, if they came in and they're like, and sometimes it is just they peed themselves, right? What was going on? Why'd you pee yourself? Oh, my water broke. Maybe, but you
Mm.
peed yourself. Why'd you pee yourself?
Ooh.
Sometimes it's just as simple as a baby kicking a bladder. Okay.
Sure. Of
So,
course. Don't start assuming
but
that anybody who came in that's not actually ruptured.
yes,
Yeah.
yes.
Yeah.
But
But
if she's coming in and she's very emotional, she's disheveled, she's shaken, she tells you that she thinks her water broke, you know.
yeah, those listening, this is a lot to ingest. For me, especially now, I've known you for a few months and we've had multiple conversations. So I'm like not quite as shell shocked as I was that first conversation. And to be honest, like I thought about you the entire way through Move and was like, I need to know more. I need to know more. So if you are feeling like I did, we are coming back next week and we're going to continue this conversation. What I want to talk about is continuing to look at the nursing assessment of what we would see. So these signs, and then I want to know what your suggestion would be on what we do, because I think you touched on it, but I have some more follow-up questions on that. I want to talk about some specific strategies on how to ask those questions or how to get people out of the room, because that's super awkward for us. So I want to talk about that. And I want to talk about your research specific to this and nurse, is it nurse confidence?
Self-efficacy, which is very similar to
efficacy.
Yeah. Your confidence is your emotional part. Your self-efficacy is how well you think you do it.
Ooh, okay. So we're going to come back for episode 2 and continue this conversation. And then we're going to have another conversation specifically about sane nursing and that forensic arm and what we can do in that realm. So like, y'all, we are on a ride, and thank you for being here. And we will be back next week with more from Morgan and this super important conversation for our practice. Thanks for spending your time with us during this episode of Happy Hour with Bundlebirth Nurses. If you like what you heard, it helps us both if you subscribe, rate, leave a raving review, and share this episode with a friend. If you want more from us, head to bundlebirthnurses.com, subscribe to our newsletter, or follow us on Instagram. Now it's your turn to take what you learned today, apply it to your life, and just sit with the information and think about what your next step is in learning more about this very pertinent and also very under-talked about topic. Check out the show notes down below for some resources if you are looking for more, and then we will see you next time.